Okay, so this lecture is going to coordinate with Chapter 17 and Adrenergic Agonist. A lot of the information, like even if you look on the Moodle book, within that book about adrenergic agonists, a lot of the information in some of those videos about like epinephrine, albuterol, a lot of it's kind of the same information. So if you find that it's a repeat of information, you can kind of scan through, this lecture or scan through the videos. It just kind of depends on how you learn. If you find that you get better luck out of watching the videos out of the Khan Academy, you got to kind of figure out your study patterns here with this. So this is going to cover Chapter 17, and it'll kind of let you know what to kind of focus on here. So looking at adrenergic agonists, there's, like I mentioned, broad spectrum of applications. They can be used for CHF, asthma, preterm labor. So looking at specific receptors in medication, so albuterol, our main receptor that we're trying to target is the beta 2, because that's where you're getting the effect on the lungs. Isoproterenol, that's a beta 1 and beta 2. This isn't used as frequently anymore because we do have better choices out there that are more selective to beta 2, so you're not getting all that cardiac effect from it, from the beta 1. Epinephrine, obviously, that's, like I mentioned before, it hits all four, alpha 1, alpha 2, beta 1, beta 2. So let's look specifically at alpha 1. Alpha 1 can affect hemostasis, so it'll stop bleeding, essentially, and that's through vasoconstriction. It also has an effect on nasal decongestion, and that's through vasoconstriction as well. So even if you think about medications like pseudoephedrine, that's how these, even like a nasal decongestant works. It's through the sympathetic nervous system. It's also used for an adjunct to local anesthetics. So sometimes if we're numbing a patient up, like if you had sutures or something that you had to put in, it actually sometimes will have lidocaine plus like epinephrine in it. The epinephrine will help vasoconstrict the area so there's reduced bleeding. It can cause an elevation of blood pressure through vasoconstriction, and then mydriasis, which is this will actually in the end result in pupil constriction because you're dilating that radial muscles of the iris. So adverse effects, and sometimes we use these to a benefit for the patient, and in other areas it actually, if we go too high with the dosing, it can cause other issues, obviously. So it's going to cause hypertension or bumping that blood pressure up. There are some medications that, are in this classification that can cause tissue necrosis. There's a lot of medications like dopamine, dobutamine, Levophed. Those are medications that you'll see commonly used in the ICU. And a lot of times it's patients that are in septic shock or cardiogenic shock. And a lot of that is to stabilize their hemodynamic status. So at that point, there are certain medications, especially like Levophed. This one you don't need to know about for this course, but it's just an FYI. Levophed, you're trying to shunt, obviously, the blood flow to your important organs, obviously, like the brain and your heart. But they can get tissue necrosis with some of these medications. So that's something that you got to kind of watch with it. Bradycardia, that can be a consequence as well. So what drugs activate alpha 1? Epi, norepi, phenylphren, and dopamine. Those are the ones that can hit alpha 1. Consequences of alpha 2 activation. Like I mentioned, we don't use a ton of drugs that work through alpha 2. One of them that is used pretty common, I guess not that common, but clonidine. Clonidine is actually a medication that can actually reduce hypertension. It can reduce their blood pressure. And it also has a concurrent use for relief of pain. It's not used that significantly anymore just because of other agents, but that's one of them. So we don't need to focus on the alpha 2 all that much right now. So for beta 1 activation, what happens when we do that? The relevant responses to activation of beta 1, it's usually related to the heart. So it's usually beta 1 receptors in the heart that we're targeting with this. There's also renal beta 1 receptors. And typically with this, there's usually not either a beneficial or an adverse effect from that. So it's mainly the heart that we're looking at with beta 1. Beta 1 can be activated by epi, norepi, isoproterenol, dopamine, dobutamine, and ephedrine. So those are all ones that are going to activate this beta 1. Therapeutic application of beta 1 activation, shock. So, like I mentioned, epinephrine, just always picture epinephrine with this. Profound hypotension and greatly reduced tissue perfusion. So, like I said, like septic shock when the patient's in the ICU. We're looking at tissue perfusion here. So that's, we'll kind of use it in that case. The primary goal is always to maintain blood flow to your vital organs. Beta 1 also increases your heart rate and the force of contraction. So in the end result, when you look at all that, if you look back at, your physiology, it's going to increase your cardiac output. And obviously, your cardiac output will increase tissue perfusion. So what are the applications that we use beta 1 activation for? One would be heart failure. If you activate beta 1 receptors in the heart, it's got a positive inotropic effect. So what that means essentially is it's increasing that force of contraction. Drugs that activate these receptors can improve cardiac performance. So it's increasing the efficiency of their heart when they have heart failure. It can also be used for an AV heart block. And this activates cardiac beta 1 receptors to enhance the conduction, the electrical conduction through the AV node. So these beta 1 stimulants can help overcome an AV block. For instance, if you have a code, sometimes it's related to lethal arrhythmia. Obviously, another one too, cardiac arrest, like I was just kind of mentioning. Drugs are only a temporary form of activation of beta 1 receptors, and they will initiate that contraction of the heart. Usually, drugs are not the preferred treatment. Obviously, we're going to look for, CPR, external pacing, like a defibrillator, and identifying why they're having cardiac arrest. Is it a perfusion issue? Is it an arrhythmia, etc.? What's the underlying cause that's, induced cardiac arrest? And then, obviously, epinephrine is used, which is used to activate beta 1 and beta 2, and the alphas, but epinephrine is used in cardiac arrest. Some adverse effects of beta 1 activation, it can actually cause dysrhythmias or angina, so they'll get chest pain because that beta 1 will increase the oxygen demand in the heart. So because you're bumping up that heart rate and the force of contraction, it's putting more workload on that heart. So patients that have an underlying, compromised coronary vessels, or if they have atherosclerosis, they're at risk for, having an anginal attack with it. Now, in terms of beta 2 is pretty much limited to the lungs, and it hits the uterus as well. So beta 2, just remember that it's always typically geared towards the lungs. This is where the medications like albuterol come in to play. And epinephrine, like I said, because it hits all of them, it will activate beta 2 in the lungs as well. Isoproterenol, like I said, we don't use it as much anymore because of adverse effects from it, but it also does hit beta 2. So those are the three that we mainly use. So what do we use, these medications that hit beta 2? It's for asthma, and it promotes bronchodilation. Because remember, if you think back to what beta 2 does, think back to these receptors. What does beta 2 do when you activate it? It causes bronchodilation. So with the medication, we're going to activate these receptors and facilitate that. We do use beta 2s to prevent or even relieve an asthma attack. Though, like I mentioned before with selectivity, there are drugs that are more selective to beta 2, so like albuterol. So you're not getting that much that's hitting on the beta 1. There is still a little bit of beta 1 activity when you use albuterol, and that's why a lot of times you'll see that tachyarrhythmia with it, or they'll have a high heart rate, or just being, they have that stimulated effect from it, because they are getting a little bit of beta 1 activity with it. Like I mentioned, less selective agents like the isoproterenol, that hits beta 1 more so than albuterol. So then you're getting more of that cardiac effect with it. Like I mentioned too, it's beta 2 also hits in the uterus, and this can be used to delay preterm labor. So if someone's having uterine contractions, obviously early when we don't want them to be, we'll actually administer medication that hits beta 2, and it will relax that smooth muscle, help facilitate stopping preterm labor. So some adverse effects of hitting beta 2 activation, and hyperglycemia is one of them. And most of the time, it's usually patients that have underlying diabetes that are affected by this. So in the average population, it's usually not that much of an issue unless the patient was critically ill or they have diabetes. but it can, bump up the sugars, and it's usually due to the receptors hitting in the liver and the muscles. So when it's hitting the muscles, there's a breakdown of glycogen into glucose. So it's going to elevate that sugar level a little bit. But like I said, it's usually more of an issue with a patient that has diabetes. In patients with normal pancreatic function, insulin release will maintain their blood sugar at a normal level. So they're going to make up for it. So the person that does not have diabetes has a normal functioning, pancreas. So they're putting out enough insulin to kind of cover this elevated sugar. Another adverse effect with beta 2 activation is tremor. And you'll see this too, like if you have a patient that is using albuterol or breathing treatments, like if they're using a nebulizer in a child, something like that, you'll notice that they get active or hyperactive. In the adults, sometimes they'll complain of tremors or they just feel shaky from it. It usually fades over time, and it's usually minimized by reducing their doses if you can. Now, let's look a little bit at dopamine activation. Dopamine it's pretty much always used in the ICU. It's used to treat shock. It can be cardiogenic, neurogenic. There's different forms of shock or septic shock. The issue with shock is usually perfusion. It's all about perfusion, and they're not getting, good tissue perfusion, and we're trying to obviously help reverse that. So one of the main things with dopamine, it's actually will dilate the renal blood vessels, and then it's going to reduce the risk of renal failure. So the patient that's in septic shock, they usually undergo like multi-system organ failure. So obviously, these are usually used in really, really sick patients, and dopamine will kind of maintain that renal perfusion. So it's going to dilate that renal vasculature. It also enhances the cardiac performance by acting the beta-1 receptors in the heart. So this is all about tissue perfusion with dopamine. Now let's look at anaphylactic shock a little bit. With this, like I said, we're trying to target multiple receptors with anaphylactic shock. Pathophysiology of anaphylaxis, it's usually related to a severe allergy. And then typically the patient will undergo severe hypotension, bronchoconstriction, or edema of the glottis. And it's not, every patient's different. Some have hypotension or some get more of the airway swelling. The treatment of anaphylaxis is always epinephrine. And like I said, because it's hitting all of those receptors, and it should help reverse some of this. Another therapeutic use of epinephrine, like I mentioned earlier, is the absorption of local anesthetic, and it also constricts, so it actually will reduce the amount of bleeding at that site as well. It elevates the blood pressure, it overcomes AV block, we kind of talked about this, and it'll restore cardiac function, and then causes the bronchial dilatation as well with asthma. And like I said, it's treatment choice for anaphylactic shock. Pharmacokinetics, it comes in different forms. It can be IM, obviously, like an EpiPen, sub-Q, or IV. Obviously, the IV would be given in the hospital, and it's usually more of the ICU setting or ER. The one kind of thing to kind of remember with this, especially when you're looking at epi for anaphylaxis, it has a very short half-life. So when you're looking at that half-life, with it being short, it's out of the system quick. So it poses an issue with patients, and that's why it's so important that we educate our patients on EpiPen use, and that they have to they have to follow up with in the emergency room. A lot of times when they're in anaphylaxis, they require second or even third doses of epinephrine. That epinephrine will kick in for that first bout of anaphylactic symptoms, but because it has such a short half-life, that allergy or the allergen response is still there, and it'll come back. So you actually have to usually treat them again with epinephrine or even steroids. That's another topic, but that's why it's so critical for them to receive care in the emergency room after having to use their epinephrine pen. Adverse effects, obviously, it can cause hypertensive crisis, which is significant elevation of the blood pressure that's beyond like just high blood pressure that's a crisis. And this is usually resulted from alpha-1 activation. And it's this dramatic increase in blood pressure, but the biggest thing is making sure that they don't have a stroke. Obviously, if you're getting that severe vasoconstriction, they can have cerebral hemorrhage from that. Other things, dysrhythmias, and that's usually just due to the beta-1 receptor activation. Patients with hyperthyroid, you have to be a little bit more careful because they're already at risk for having dysrhythmias. So if they're on epi or you're giving them epinephrine, this could be potentiated. Another effect too is angina. Obviously, it can cause chest pain because you're vasoconstricting and you're increasing that workload on the heart. So, I mean, anybody has underlying cardiac history, just you have to watch with them and be careful with this. Tissue necrosis after IV extravasation, that's basically if your IV comes out, it can cause tissue necrosis because it is a potent vasoconstrictor. So that's something you have to be very careful with, especially in the pediatric patients because they're obviously their tissue is more fragile. So if this does happen, usually we'll give an alpha adrenergic antagonist to kind of reverse it. And that's usually done through local injection into the tissue. Hyperglycemia, it's kind of like I mentioned earlier, when you're hitting those beta cells, patients with diabetes, it can cause hyperglycemia in them. So with the hyperglycemia, really all you can do is adjust the dosage of their medications and just kind of monitoring it. These are just different preparations of it, how it comes in multiple forms. It even comes in intracardiac. It's very rarely used. There's actually spinal ones that they use to inject. There's inhalation, which will cause bronchodilation. And then there's also topical as well. Now, real quick, let's look at isoproterenol, because like I said, we don't use this one all that much anymore. So the ones that I would focus on right now are like the epinephrine, albuterol. Take a look at dopamine and dobutamine, but mainly looking at like what does beta 1 do? What are the effects of it? What if you hit beta 2? Like kind of on the overall understanding here. So isoproterenol, it hits beta 1 and beta 2, so that's why it has other side effects with it. It does have fewer side effects than norepinephrine and epinephrine, but we don't use it all that often anyways. So dopamine, we already kind of touched base on this. In terms of the receptors, it kind of depends on the dosing of dopamine. If you're giving it a moderate to lower dose of dopamine, it's mainly hitting that beta 1. And this is where you're getting that kidney protection with it. If you're at really high doses, then you're going to hit the alpha receptors and then beta 1 and dopamine alongside with it. It depends on the dosing of it. Like I said, it's usually used in the ICU. It's mainly used for shock, heart failure. Adverse effects is the tachycardia, dysrhythmias, chest pain, or tissue necrosis. Dobutamine, this one works at beta 1. It's mainly used for CHF, or it can be used in shock as well. Sometimes we'll have patients on like dopamine and dobutamine. They'll be on both of them. It just kind of depends on the patient's state and the type of shock that they have, to be honest. And then let's take a look at albuterol, because that's the other one I would focus on is albuterol. And we'll talk about this as we go through respiratory, but just so you get the understanding of the beta and alpha receptors. So albuterol hits beta 2. It's used for asthma. And there's long-acting, short-acting beta 2 agonists for asthma. And usually at the lower dose, like the therapeutic doses, usually there's not too many side effects with it. Like I said, tremor or hyperactivity can be common when you're at the higher doses. It can cause tachycardia because it can hit that beta 2 a little bit. It's not wholly selective to beta 1, so there's a little bit of beta 2 activation, and then you get tachycardia with it. So these are the drugs that I would kind of focus on when you're studying. The main ones being epinephrine and albuterol, because that gives you a good idea of beta 1 and beta 2 activation. The other ones, like I said, they're more used in the ICU setting. It's good to have knowledge on them, but you probably won't come into contact with them all that much unless you're working in the ICU setting. But the albuterol and epi, obviously, those are ones that are extremely common, and you definitely need to know. So if you have any further questions on this lecture, just please let me know. A lot of the content in the Moodle book kind of compares with this. So like I said, just kind of take a look. If you feel like it's a repeat of certain things, just kind of browse through the other stuff. So if you have any further questions, let me know. Thanks.